about, just over an hour ago, I sent you guys some documents. There's a horrendous Word document that I made that's sort of summarizing in 16 short pages the little bit I think I know about cachexia, along with I think 3 articles that are kind of review articles that talk about at least some of the stuff. Yeah, it's pretty horrible, actually. So we're just going through that Word document. We're just talking about some interesting facts about cachexia. Probably the most interesting ones, for me anyway, was that cachexia is actually the direct cause of death in 20% of cancer deaths due to wasting of diaphragmatic and cardiac muscle. Basically, your respiratory system or your heart just completely fails, and that's why people die. And also, cachexia not only makes people less tolerant to treatment, but also respond less well to treatment when they're cachectic. And cachexia is, although it's associated with anorexia, it's not the same pathophysiology at all as starvation. So muscle wasting and weight loss in cachexia is not just because of lack of nutrition. And then it costs a lot of money, obviously. We were just starting on the definitions in that document. We're talking about sarcopenia, which is essentially loss of muscle mass and strength. Sarcopenic obesity is a kind of important concept because people who are obese can have a low lean body mass and still be and still have some of the symptoms of cachexia. And some of the outcomes, like doing less well with treatment, tolerating treatment less well. But it's not always recognized because people can be overweight. But that's due to excess fat and water, not because of muscle. Cachexia, so there's a Cachexia consensus conference in 2008. And this definition that I saw all over the place: cachexia is a complex metabolic syndrome associated with underlying illness and characterized by loss of muscle with or without loss of fat mass. The prominent clinical feature of cachexia is weight loss in adults corrected for fluid retention or growth failure in children, excluding endocrine disorders. Anorexia, inflammation, insulin resistance, and increased muscle protein breakdown are frequently associated with cachexia. It is distinct from starvation, age-related loss of muscle mass, primary depression, malabsorption, and hyperthyroidism, and is associated with increased morbidity. And then there's a specific definition for cancer. Cachexia is a multifactorial syndrome characterized by ongoing loss of skeletal muscle mass without a loss of fat mass. It cannot be fully reversed by conventional nutritional support and leads to progressive functional impairment. The pathophysiology is characterized by a negative protein and energy balance driven by a variable combination of reduced food intake and abnormal metabolism. So, I kind of hummed and hawed about whether to do pathophysiology next or go to assessment, because pathophysiology and treatment kind of go together, but in the end I just went with pathophysiology first. So it's a very complex disorder, I guess would be the word. The picture that's on that page 3 is a hyper-simplified version of I looked at a whole bunch of different diagrams, and there's no way to get all of the different organs, all of the different systems, all of the different cytokines and proteins and hormones and things like that all in one diagram and have it be readable. So I thought this one looked fairly simple, it looked fairly accurate, and had some of the important concepts on it. It's a hypermetabolic state, which is different than starvation, with significant loss of total body mass, anorexia, inflammation, increased resting energy expenditure. So basically, it's kind of saying that almost the same thing as hypermetabolic. The body actually uses more energy rather than less, and it's also characterized by muscle wasting. and this results in decreased quality of life. Can't be reversed by nutritional support alone. So that diagram kind of shows you that there are host factors and tumor factors that are produced in the face of some kind of chronic advanced illness that all in various ways and in sort of interacting with each other produce a whole bunch of different things, including anorexia, lipolysis, and proteolysis, so breakdown of fat and protein. Hormonal homeostasis is perturbed, resulting in reduced anabolic signaling. That's particularly in men, and also impaired myogenesis, so muscle production or repair actually is decreased. That all leads to muscle wasting, loss of fat, and body weight loss. So there's a whole bunch of different systems and organs and all kinds of different things that participate to varying degrees and depending on the disease in cachexia. So the immune system, this is kind of the big ticket item as far as cachexia goes. Most of the immune factors are actually released by the host immune system. The three main ones are tissue necrosis factor alpha, IL-1, and IL-6. So you see an elevated CRP often in people with cancer cachexia, which is one of the biomarkers we'll talk about a bit later. So these things seem to induce cachexia in animal models, and also induce related symptoms. And if you block them, you can sometimes improve cachexia and muscle wasting in animals. And there's there is some evidence that actually treating inflammation can or slow cachexia progression. So tumor necrosis factor alpha, which is also called cachectin, promotes anorexia, fatigue, skeletal muscle wasting in patients with cancer. And by blocking tumor necrosis factor alpha, we're hoping that we're going to be able to block cachexia, although so far there isn't a whole lot of evidence that works all that well. Probably the most common treatment for that is thalidomide, which does get used for this, usually with other things. IL-1 also promotes anorexia, and increased IL-1 beta is associated with decreased survival. And then there's a whole family of IL-6 cytokines, which seems to drive cachexia in mice at least. And circulating levels correlate with development of cachexia and poor prognosis. So I had a kind of a hard time trying to organize pathophysiology beyond the cytokines. In the end, I went with, I think, one of the articles that I sent you organized it mostly by organ and organ system, and skeletal muscle being one of the most important ones. So in cachexia, there's a decrease in protein synthesis in muscle due to things like anabolic factors that are decreased, like IGF-1, and increase in degradation factors like angiotensin II, IL-6, myostatin, a whole bunch of other things, including TNF-alpha, interferon gamma. So basically, you make less muscle and you break down more muscle. At the cellular level, there's three main pathways that this happens by. The most interesting one is the ATP ubiquitin-mediated proteasome degradation, which is also called UPR. Excuse me. This is thought to be maybe the final common pathway that actually leads to protein degradation in cancer, at least. There's evidence for this in mice, not so much in humans. There's early clinical trials of something called ACT-R2B, which blocks an element of that pathway. And this, at least in animals, seems to prevent further muscle wasting versus prior muscle loss and may prolong survival. So promising for mice anyway. There's something called autophagy, which when I actually Googled this, thinking I'd just figure out what it meant. And what it is a natural process of destruction of cell components by lysosomes. So there's a whole like alternative medicine thing for promotion of autophagy, which is actually, it's interesting because it leads to cachexia. If you stimulate the autophagy, I'm not even sure I'm pronouncing that right, but it's not a good thing. But people do it on purpose. They try to do it on purpose to clean up their cells, to clean up unnecessary, unwanted, no longer, but not so much toxins, but parts of the cell that you don't need anymore. It cleans them up. So apparently, well, things that they get worn out, or like old ribosomes. I don't know what they are, but old things that we don't need anymore. That's kind of the idea. Is your house cleaning by starving yourself. Yes. And then calpain proteases, which I couldn't find much information about, but they possibly initiate the degradation process of cachexia. There's not a whole lot of information about them, and they're basically sort of things people think they may be involved somehow. So there's other things that happen in muscle tissue that probably contribute to this. There's a population of cells called satellite cells, which when skeletal muscle gets injured or and their regeneration is necessary, these satellite cells get activated and differentiated to do that. That gets deregulated in cachexia, we think. And then tumor products probably actually also directly cause cell death in skeletal muscle tissue. There's probably some contribution by impaired mitochondrial metabolism involving something called uncoupling proteins, which result in increased oxidative stress and increased energetic inefficiency. So that's probably what's responsible for increasing the resting energy expenditure, or the inefficiency of energy use. And then in cardiac muscle, there's a similar process of muscle wasting, which can lead to CHF and arrhythmias, which are the main causes of death in cachexia. It's kind of interesting. The reason I kind of went into the detail there is that there are some treatments coming up that are looking at how to use those things to find ways to combat cachexia. Long times it's I've been talking about autopsies. I actually did autopsies. I don't know exactly what it was in the autopsies, but so that's what caused. Yeah, a curious person. No, but heavens no.
Their initial cancer is causing death, but I wonder if it's more like an assumption.
No, it's actually that autopsy.
A cancer that's progressing in cachexia and die. It's hard to differentiate.
Yes, yeah, I think it's like any autopsy, but the reason is the actual cause of death. I don't know how they did that, but so the liver contributes as well, and it probably does this by promoting hypermetabolism, and therefore increased energy expenditure. The liver actually gets bigger during cachexia, and probably due to increased gluconeogenesis, which is very energy demanding. So it produces more glucose, which is mostly then taken up by tumors and used by tumors. And it's thought that maybe this is partly due, not completely, but partly due to decreased lipogenesis, which through a series of steps that I don't really understand, actually promotes liver, promotes gluconeogenesis. And the liver also decreases albumin production in response to IL-6 and TNF-alpha. Fat also participates in cachexia. So all of the cytokines plus something called zinc alpha-2 glycoprotein lipid mobilizing factor, or ZAG-LMF. All the cytokines and the ZAG-LMF seem to promote breakdown lipid mobilization. So people with cachexia actually have higher circulating levels of free fatty acids, glycerol, which is something that I don't really remember ever knowing very much about adipose tissue, but apparently brown adipose tissue has enriched mitochondria, which increase any energy expenditure and affects switch from normal white to brown adipose tissue, which is probably where we get part of where we get the increased energy expenditure. And then fat tissue wasting actually seems to stimulate skeletal muscle wasting. So therefore promoting cachexia. So sometimes fat loss actually comes first, but it's not required for cachexia. So the brain also participates in cachexia, mainly through pathways regulated by the hypothalamus. So it regulates both food intake and body energy expenditure, and it does so in response to multiple factors. So gastric distension results in vagal stimulation, which tells the hypothalamus that the stomach's full, and then it should stop eating, or tell the body to stop eating. It also, and this is where I don't know if you guys have heard much about the ghrelin or ghrelin, I'm not sure how to say that, the ghrelin hormone, which is a new word for me, but it makes sense, orexigenic, which is the opposite of anorexigenic. So ghrelin actually promotes food intake, and it does that by acting on the hypothalamus. And then there are anorexigenic hormones as well, including insulin, several, but one of them. And then there are some more central factors, neuropeptide Y, which promotes food intake, and something called POMC. Well, there's a typo, what that stands for, which is anorexigenic. So all those things act on the hypothalamus to regulate intake and body expenditure. In cachexia, the hypothalamus seems to become resistant to some of these signals, at least the ones that promote increase in appetite. So in cachexia, the level of ghrelin or ghrelin actually goes up, but the hypothalamus no longer responds to it. And the hypothalamus becomes more responsive to anorexigenic factors. And this seems to be associated with TNF-alpha, interferon gamma, IL-6, and also some anti-inflammatory agents, anti-inflammatory agents actually ameliorate anorexia and cancer, probably by acting on the inflammation that all those cytokines are part of. The change in taste is thought to be mediated through TNF-alpha, which It's a bitterness perception. The whole point of all this happening from an evolutionary perspective, it's thought to be that at least in acute infections, it's felt that it's probably beneficial to eat nutrients that bacteria need, so the bacteria all die. It's a little bit of seems like a kamikaze kind of a way to do it, but that's what we think. And there are some tumor-derived factors that also seem to promote anorexia through the hypothalamus, the whole hypothalamic system. And then, apart from just anorexia, the hypothalamus does seem to also increase energy expenditure and plays a role in glucohomeostasis, but we're not sure how that all fits the whole picture. So, sorry. I don't know. There's no way to make this interesting. So I'm going to talk really fast. I try not to do that. So the pancreas is also involved. So insulin resistance. Interestingly, I didn't know either of this, but it's a risk factor for cancer development, which I think probably did kind of know. But it's also a result of cancer development. So people who develop cancer are more likely to develop insulin resistance. Well, I knew diabetics were more. I knew diabetics were more prone to probably by a very indirect route. I just thought, oh, it makes sense because maybe it's more to do with obesity. I don't know. It made sense anyway. I certainly didn't know that insulin resistance would be a result of cancer development. And it worsens with cachexia, and degree of insulin resistance actually correlates with risk of mortality in people with cachexia. So increased insulin levels promote tumor growth, so they actually make cancer worse. It's an anabolic factor. So insulin resistance, which is in part how insulin resistance can lead to muscle wasting. It is no longer, the body is no longer responding as well to the anabolic action of insulin. So insulin actually also promotes liver gluconeogenesis, which increases energy expenditure, tissue wasting, and fuels cancer glycolysis. So basically, the cancer tissue has more to eat, which is the only way that makes sense to me. And then you can actually treating mice with cachexia, so mouse models of cachexia. You can actually improve cachexia by treating with insulin sensitizers, and also humans treated with insulin actually their cachexia does seem to improve. So increased production of glucagon also with cancer progression, gluconeogenesis, and if you can normalize glucagon levels, that does seem to actually cachexia progression.
Normalizing orexigenic.
Yes. Some of these hormones, they seem to all work towards the same goal, but some of them do different things. And probably some evolutionary reason that has nothing to do with nothing to do with cancer cachexia. So the GI tract. Disruption of the gut barrier, so if you have an actual GI tumor, can lead to decreased absorption of nutrients, and also increased systemic inflammation, alteration of the gut flora, which can happen for multiple reasons in cancer, can also decrease absorption and availability of some metabolites in the gut. And then probably the most interesting contribution of the GI tract is this ghrelin hormone, which is again an orexigenic peptide produced mainly by the stomach, which actually promotes appetite, but also increases adiposity, decreases resting energy expenditure, pairs muscle adiposity, so increases the amount of fat that find in muscle. So that's what it does normally. And the levels actually increase in cachexia, probably to try and offset the fact that cachexia is associated, as I said before, with resistance. So anamarelin, I don't know if I'm pronouncing that right either. Maybe anamarelin, all kinds of different pronunciations. Is an analog of ghrelin. Basically, does the same thing as ghrelin. Looks like it may improve appetite and muscle mass, at least people with cachexia. We'll talk about that later. So there's a bunch of random other things that can contribute to, not really random, they just seem random to me, so I put them all under miscellaneous. So this JAK-STAT pathway, the JAK stands for Janus kinases. They mediate cytokine signaling by activating the STAT transcription levels. I could not figure out very well what the STAT transcription levels actually meant, but it looks like the JAK-STAT pathway is involved in a lot of solid tumors and also in cancer-induced muscle wasting. And this is interesting because they found that a JAK inhibitor, roloxatinib, whose other name is Jakafi, which I've heard of. They use it in like some, yeah, it's like some kinds of leukemia. I think I've seen it a few times.
Yeah, lady, like MDS or
yeah, maybe myelosuppressive disorder. Yeah, that's right. Yeah.
I think yeah, but she was on Jack. Transfusion dependent.
Anyway, they're using that for some reason to try and treat people with advanced pancreatic cancer that was refractory to gemcitabine, and they were trying capecitabine plus or minus roloxatinib, and for most of the people in the study didn't seem to do anything, but in the subset of patients who actually had an elevated CRP, so sign of systemic inflammation, it did actually improve the 6-month survival rate significantly. I think it went from 11 to 40 something percent. So if there's systemic inflammation, then this JAK-STAT pathway inhibitor does seem to improve survival. It's a bit of a tenuous link because it wasn't actually looking at people with cachexia, it was looking at people with systemic inflammation. But anyway, possibly a tenuous link someday. So then just cancer treatment itself can also contribute to cachexia. So androgen deprivation treatments can result in muscle wasting, which is important in prostate cancer. Sorafenib, which is a tyrosine kinase inhibitor, and bevacizumab, which is a vascular endothelial growth factor inhibitor, both decrease skeletal muscle mass. And then cancer treatment can also alter taste and smell, contributes to anorexia. So the cancer itself can contribute to cachexia because it can cause dysphagia, abdominal pain, abdominal distension, which can result in decreased food intake. Then early satiety due to organomegaly, abdominal masses, ascites, which is similar, related to decreased food intake. Decreased GI motility, malabsorption, intestinal invasion or resection of the intestine. There are symptoms called secondary nutrition impact symptoms, which will come up again when we're talking about assessment, which are basically symptoms that have an impact on nutrition of people's ability to take in nutrition, and those include pain, fatigue, xerostomia, nausea, constipation, and depression. And then finally, tumor-derived parathyroid hormone-related protein, which is implicated actually in hypercalcemia malignancy, may also have a role in cancer-induced weight loss, at least in mice, sick mice.
And I don't know if we're going to cover this later. I didn't see it in I mainly read up to date, and it was kind of, it mentioned this sort of back up this, the sorafenib and the bevacizumab. I just wonder with those patients, if early intervention with nutrition or something, if it's known to do that. Anti-deprivation therapy, I think we've all kind of known that is, but still they should have this either exercise and alongside it, because they're on it for years. But it was just when I was reading up to date, I was like, oh, I wonder. This is really tricky question. You're right. Anyway, I've never heard of that before.
No. Yeah, and I don't know, because it's muscle wasting. Nutrition, I don't know. I don't even know whether you have feeding them up or
like
what would actually
actual exercise program or it's not like it one cause.
Yeah. So, and then there's medications can contribute. There's a list there. Amphetamines, that was number one. Of course, our opioids, ranolazine, which I've never heard of before, and a bunch of other medications that are not that uncommon. Aging itself can contribute to pathophysiology or pathogenesis of cancer, cachexia. There's just a few notes on non-cancer cachexia, cardiac cachexia. Many of the mechanisms are similar to what we talked about already. Most of which is taken from cachexia models, but the activation of the angiotensin aldosterone system, is also thought to maybe contribute somehow to cachexia in cardiac disease. And then they also mentioned the possibility of decreased bowel perfusion or edema because of heart failure may lead to nutritional deficiencies and fat malabsorption. For pulmonary cachexia syndrome, which is basically what we see in end-stage COPD, there's likely an increased level of myostatin, which is a negative regulator of muscle growth, which is a significant problem in COPD. The muscle wasting in COPD is probably more pronounced than even in other diseases. Lack of exercise and fatigue, because of shortness of breath, also probably contributes to cachexia in pulmonary disease. And then tissue hypoxia can lead to muscle wasting, but likely also probably fat wasting. And then in chronic kidney disease, along with everything else that we've talked about, vitamin D deficiency and metabolic acidosis both contribute to cachexia. Metabolic acidosis particularly involved in or can cause muscle wasting. So that's some of the pathophysiology of cachexia. I spent quite a lot of time, probably more time than I should have maybe, on diagnosis and assessment, although I thought this might be where we get questions, and there's a lot of sort of definitions, grading systems, scoring, things like that, which are talked about in the literature, and there's been quite a bit of work done on the cachexia assessment. I know. I thought I'd just throw in a few of the ones I saw more commonly, along with some that I thought seemed like good advice as far as I don't think you have to memorize these by any means. I'm not going to. It is recommended that there's routine screening for nutritional deficiencies, cachexia, in patients with advanced disease of any kind. This should include history, which looks at dietary intake and patient reporting of anorexia, factors that decrease the ability to take in nutrition, so dysphagia, early satiety, all those things we kind of talked about already. Functional and psychosocial impairment is really important, and that we'll talk about that again in a little bit. And then the physical exam should be focused mainly on muscle wasting, and particularly looking at decreased bulk and tone of the temporal muscles, deltoids, and quadricep muscles. Looking at loss of subcutaneous fat, and also looking at edema and ascites. And they talk about the most common way of measuring and following people for these cachexia, measurement of body weight. That's not following people with cachexia. That's actually cachexia. So as far as diagnosing cachexia, this got really complicated because there's different ways of looking at diagnosis. There's sort of a whole bunch of different definitions of cachexia based on actual assessment of the patient, rather than just the definitions that we talked about earlier. Probably the three most talked about ones are one in a paper by Fearon et al., which requires 2 of weight loss more than 10%, low food intake less than 1,500 calories a day, and or systemic inflammation, so a CRP greater than 10. There's another one by Evans who talks about weight loss greater than 5% over 12 months, along with underlying chronic disease, or a BMI of less than 20. So one of those things, plus at least 3 of those the next whole bunch. So abnormal biochemistry, CRP greater than 5, hemoglobin less than 120, albumin less than 3.2, fatigue, I think by 3.2, though, I think I would usually see that as 32. Yeah. Fatigue, anorexia, decreased muscle strength, muscle depletion. Yeah.
I think weight loss equipment, is it like from their baseline weight,
yeah.
Not over time frame?
Yeah. So it's from their baseline, whatever they were when. Then the European Palliative Care Research Collaborative also has their own definition, which is weight loss greater than 5% over the past 6 months without evidence of starvation, and or weight loss more than 2% over that period, and BMI of less than 20, and or weight loss of over 2% over that period, and evidence of sarcoma. So that's kind of how you can diagnose. You just pick one. Okay. I think the European Palliative Care Research Collaborative, I think, what's his name? Rivera, yes. He's involved in that. So if he's in any way involved in writing the exam, I don't think we have to memorize these things, but if we do, if you want to, I'd memorize that one. And then there are grading systems, which are really quite horrible to try and figure out. But I put in a bunch of them in case anyone was interested. Fearon et al., the same one that had the definition above, talks about different stages of cachexia. That's quite simple. It's based on BMI and percentage of weight loss. So they talk about pre-cachexia being weight loss less than or equal to 5%, anorexia, and metabolic changes. That's kind of where they suggest monitoring preventative interventions. Cachexia itself is weight loss greater than 5% or BMI less than 20 and weight loss of 1%. It's often reduced intake or systemic inflammation at that point. And they suggest a multimodal management according to the patient's phenotype, and putting the priority on reversible factors. And then they talk about refractory cachexia, which is a variable degree of cachexia in the presence of a cancer disease which is pro-catabolic and not responding to anti-cancer treatment, low performance scale, less than 2 months expected survival, and at that point they just suggest palliation, psychosocial support, and an ethical discussion regarding nutritional support, with the I think being on not likely to help you very much. It can make you feel better, but it's probably actually. I put in some information on the CASCO, which is for Cachexia score. There's a numerical score assigned to several factors, and the total score gives corresponds to either no cachexia or mild, moderate, severe cachexia. And this is a validated scoring system. In the references that I looked at, it didn't actually describe exactly how to do it. But basically these scores, you have to be trained to use the CASCO. And they look at body weight loss and composition, inflammation, metabolic disturbances, immunosuppression, physical performance, anorexia, and quality of life. So all those things are taken into consideration. You get the score and figure out where the patient is on the spectrum of cachexia. It involves imaging studies, laboratory tests, a number of questionnaires, not just one questionnaire. So it's really not probably feasible to do it in any but experimental conditions. They did come up with a mini CASCO, which is less onerous, and there seems to be the results are consistent with the CASCO. And so that looks at weight factors, body weight loss, lean body mass, some lab values, including plasma albumin, anemia, CRP, absolute lymphocyte count, which is a measure of immunosuppression, and a list of questions regarding physical performance, anorexia, and quality of life. So you combine that, you get a score, and they seem to be able to use that. So it's a little bit more doable, and I think they probably would use that one in cachexia clinics, which I can't imagine we would ever have here in St. John, but the palliative care specialists that are specialized in cachexia and have clinics that do only that, we may use that. There is also a grading system based on BMI and percent weight loss, which is associated with prognosis. Again, I don't know how practical this one is. It's doable, and it actually gives you an idea of prognosis. It goes from grade 0 to grade 4, and it really just uses percent weight loss and BMI. So grade 0 is basically stable weight, BMI of over 25, which actually puts you in overweight category. I'm focused on BMI at the moment. So the median survival of those people is 29 months. I won't go into, because it gets really complicated around grade 3. There's different, like, depending on what your BMI is, there's different amounts of weight loss that put you into each grade. But basically, the higher the grade, the lower the survival. Grade 4, you can have a BMI, if you have a BMI of less than 20, which is underweight, and weight loss of 6 to 11% compared to previous, or BMI less than 22 and weight loss is 11 to 15%, or your BMI is less than 28 and weight loss is over 15%, median survival is expected to be 4 months. So the other grades are basically combinations of different BMIs and different degrees of weight loss. So then probably the most important part of this section is the 4 major aspects of assessing cancer cachexia, plus some more that I added myself. So these 4 major aspects are actually recommended by, I think, that EPIRC group and by other groups, as they're kind of internationally recognized as the things that need to be assessed when assessing cancer cachexia. So you need to do nutritional screening and assessments. There are screening tools that have been developed for this, but none seem to be optimal. They all have problems. There's the mini nutritional assessment that gets talked about, malnutrition universal screening tool, which is also called MUST, and the nutritional risk screening 2002 have been used, but there are problems with each. There's something called the Patient-Generated Subjective Global Assessment, PGSGA, which is completed by the patient and the practitioner both. It looks at weight loss, appetite, food intake, activity, and function, as well as metabolic demand and physical assessment. And that's probably the one that is preferred for, at least for patients with cancer. You also should be assessing, as part of nutritional screening, appetite, and ESAS probably the best way to do that. The secondary nutrition impacts symptoms that we mentioned before, these are it's important to look at these as other things that may impact appetite and ability to take in nutrition. That includes pain, xerostomia, nausea, constipation, depression, satiety. And then other things that contribute, hypogonadism, especially in men with cancer. I think one study looked at males referred to a cancer cachexia clinic. 52 out of 71 males with cancer referred to this clinic had signs of hypogonadism. The benefits of testosterone replacement are not really all that clear. We'll talk about that again. Hypothyroidism is important. This is more common in people treated with tyrosine kinase inhibitors that target vascular endothelial growth factor. Bevacizumab, as we mentioned before, sorafenib as well, apparently. Adrenal insufficiency. Yes, so people with, particularly in people with bilateral adrenal metastases or anything that makes you suspect they might have some adrenal insufficiency. Gastroparesis is important to look at, often associated with early satiety. That can happen due to chemotherapy-induced autonomic dysfunction, some medications, such as our favorites. Radiation enteritis, tumor infiltration of the stomach, and also probably something we should put as part of our answer to every question: perineoplastic can result in gastroparesis. And then again, the cancer treatments that are associated with sarcopenia, it's important to ask about these or be aware of these: androgen deprivation therapy, sorafenib, bevacizumab. So that's all part of nutritional assessment. Second important thing or area to assess is muscularity and body composition. This is basically looking at muscle mass and muscle strength. So for muscle mass, the gold standards, if there is one, is CT or MRI. Dual energy, I put ER there, but it's supposed to be XR. Dual energy X-ray or DEXA. Bioimpedance analysis is also done in cachexia clinics, some cachexia clinics. And then probably the more simple one would be mid-upper arm circumference skin fold measurement. All of these have some, are not perfect, but the CT are probably the best ones. I can't imagine most of our patients doing an MRI to see whether or not they're cachectic. I can't imagine, but most of our patients have had, we're looking at them for this may have had a recent. So the third area to assess is the quality of life and psychosocial assessment. So there we need to be asking about negative emotions due to involuntary weight loss or reduced dietary intake, altered self-perception, embarrassment, obese. It's important to watch out for obese individuals who may actually be happy about this weight loss, which is actually a dangerous thing because we talked about sarcopenic obesity. Losing muscle mass is not actually a good thing. And this may lead to people actually not wanting to treat this, which can actually make their whole disease process worse and make them less responsive to treatment if we can't reverse it. It's important for education and support of caregivers is important, as a result of relational conflicts, as we've all seen many times. Not that you can always educate caregivers, or at least why this is happening. There's a variety of quality of life assessment tools available. None of them are fully validated for use in this. One that came up quite a lot was the functional assessment of anorexia cachexia therapy, or FACT. This is specific for cancer cachexia. It's a 39-item assessment tool that looks at a wide variety of physical, functional, social, emotional, and sexual spheres. And I think it's probably, I don't know, I think they do use this in cachexia clinics. Not sure they use it. I've never seen it used anywhere else apart from studies on treatment for cachexia. And then finally, biomarkers for cachexia is another important area to look at when assessing cachexia. Assessing cachexia and assessing for cachexia. So what they mean by biomarkers is any measurable substance in the body, either influential or predictive of the incidence, outcome, or treatment response of disease. So there are quite a lot of these. CRP is probably the only really practical one that I could see as a marker of systemic inflammation. Albumin kind of fits under there as well. Certainly that's a look at as far as nutritional status. But those things are measurable. Apparently IL-1 alpha, IL beta, IL-6, IL-8, TNF alpha, and IL-10 also increase and are measurable, but I don't know that we actually would measure those. Other things that change are some hormones, so the ghrelin increases, testosterone, and other factors decrease. Testosterone, I think we would measure. I don't think we really measure routinely anything else. Some adipose-derived factors are apparently biomarkers, but not likely to be something we would measure on a regular basis. The ZAG-LMF thing that I talked about before, the zinc alpha-2 protein LMF, is something else that changes in cachexia, a bunch of other things that I know I'm never going to measure. And probably wouldn't even write on exam that I would measure it. I mess up say it wrong or something, maybe. Yeah. Other things that are practical to measure is CBC, so anemia, and also absolute leukocyte count, immunosuppression.
Maybe that's
Never look at. Yeah. The most I might look at.
Yeah. I just ordered a stat CBC and someone. Hold on. I just
see it's all there.
Yeah, I just we mainly were looking at Luke's hemoglobin platelets, maybe neutrophils. That's all I really look at. There's a lot of stuff.
Yeah, I always thought, why the hell? Who looks at that? Absolute lymphocyte count is low.
Anyway, it is interesting. It does come on it as a marker.
I guess I was kind of just thinking that it was because neutrophil count is. I just assumed. So the last section, we can stop here and see if anybody has any comments or questions or anything or just wants to rest their brain for a second.
Absolutely.
Yeah.
Lymphocytes.
0.5 lymphocytes. There's low.
I know. I don't know. Want to have a look at it. Yeah, look at your lymphocyte difference.
The neutrophil, all that.
Yeah, right. Right, it probably is that. It's probably right, because some of the papers refer to neutrophil count as ANC. So it's probably or absolutely. Yeah, ALC. Alternative level of care. And,
my brain. Oh, but it's not going to get any better. Anyway, it's not going to get better. And really, this is something like I feel like my purpose in this was to produce this document so that I can like read it again at some point and remind myself, and maybe not. I'll never remember everything, and I don't think there's any need to. But it gives you like I feel like for the assessment, it gives you an idea of the areas that you should be touching on, like how you actually go about it is maybe not that important. Well, but just and then there's some buzzwords. The treatment, I don't know either how important that's going to be, but none of it's important. None of it. Well, mostly because there's not a whole. I mean, you probably know all the important things already. Anyway, so there's a whole bunch of different things. Everything I read about, I didn't list here. Some of it was this thing. Somebody tried it, like melatonin. Is used sometimes. I didn't actually include about melatonin, although it is mentioned. I just thought I'd kind of limit myself somehow. Probably did things, but there are several treatments. There's a lot of work being done on treatment of cachexia at the moment, based on a lot of the cytokine stuff, hormonal stuff. Some of it's quite promising. Some of it looked promising and didn't go anywhere. So there's oral nutrition interventions that are mentioned in the literature. This usually refers to dietary counseling and encouragement of using high energy foods, things called fortifications, which I think are basically vitamins and minerals, and oral liquid nutritional supplements, as they call them, which I'm assuming they mean boost onshore. So there is some weak evidence that this can improve energy intake, reduce weight loss, and improve participation, leisure activities, and psychological functions. So it can make people feel better and do better. There's not a whole lot of evidence that it actually patients report it improves their quality of life, and it doesn't affect mortality. So I think that's probably good information when you're talking to families about what we can actually do by nutritional type of interventions. L-carnitine supplementation, I kind of stuck this in here. It does get mentioned quite a bit. The treatment dose is 4 milligrams per day. Does seem to increase BMI, can increase survival, reduces hospital stays, improve GI symptoms, quality of life, and weight. So that's something to think about. It's like an amino acid kind of thing. Yeah. No. Yeah, no.
I mean,
and no, I know. I think I've heard of it before, but I didn't do it. I never myself. And it's when we'll talk more about combinations, and it's combination therapies may or may not be any better than on its own, better than a lot of other things. Artificial nutritional support is really talking about TPN tube feeding. For the majority of our patients, artificial nutrition does not prolong life or improve functional status. Not indicated. There are a few situations where it might be helpful or should be considered. They talk about home TPN being helpful in some patients with, for example, high-grade bowel obstruction or malabsorption with a prognosis of at least several months and good functional status, which is not always the case for people who seem to want TPN. And then they talk about equivocal or controversial recommendation for long-term tube feeding for patients with dementia, neuromuscular disorders, or other neurodegenerative disorders where people either can't or won't eat. There have been systematic reviews regarding this don't show any evidence of increased survival, prevention of aspiration, improved nutrition, or alleviation of hunger and thirst, which are the reason for that kind of artificial nutritional support. So that's been mentioned too. I'm going to talk about two other disorders. Exercise can be a treatment for cachexia. Probably is mostly helpful, mostly helpful in people with lung issues, particularly lung cancer. Excuse me. And because one of the large important causes of death in cachexia is lung cancer failure. Exercise. There's not a whole lot of evidence otherwise for exercise, except maybe in COPD. I'll mention again. We probably don't wait until it's really. And we talked about high intensity interval training. And these were people on treatment, so they well enough to have chemo. Yeah. Cannabinoids come up a lot because of the appetite stimulation associated with them. Most of the resources I looked at did not recommend using cannabinoids for this, except in specific situations. So they looked at nabilone, which showed no difference in weight, appetite, or quality of life compared to placebo. It is, however, indicated for chemotherapy-induced nausea vomiting, so if that is likely contributing, then it will help with that. Dronabinol, which we can't even get here in Canada at the moment, increases appetite but not weight gain in HIV/AIDS, but there's no evidence for using it for anorexia, cachexia, disorders including cancer. So it doesn't actually increase appetite gain. And then cannabis sativa derivatives, including THC mix and THC did not show any effect on appetite with change in quality of life. A whole lot apart from appetite, with nothing there for cannabinoids, evidence-wise. Then corticosteroids, which work by stimulating appetite, suggest trials of dexamethasone, 4 milligrams a day or less, prednisone 40 milligrams per day, or methylprednisolone. Find a dose for that one. Not entirely clear how it actually does this. Probably forogenic effect, anti-inflammatory effect, hopefully, and maybe stimulation of the hypothalamus, and the exogenic hormones stimulate the hypothalamus. So this has been found to improve appetite and sense of well-being, but not weight gain. Effect duration is short, usually just a few weeks, and can be associated with long-term negative effects that actually make things worse. Myopathy, Cushingoid body habitus, and peptic acid disease, all of which were actually worsened in cachexia. And there's no evidence for using it at all outside of cancer, so it's not for COPD people. Progesterol acetate, dose range there, it's 160 to 800. But less than 160 is not found to have much of a benefit, and over 800 it's associated with increased adverse events. So that's the dose recommended. It does result in decent appetite and weight. Its efficacy is similar to dexamethasone for those things, which is interesting because when they were talking about dexamethasone or corticosteroids, they talked about it not improving weight gain. But Megace, they talked about it actually being the same as dexamethasone and improving weight gain. But the toxicity as a result of Megace leading to discontinuation was actually worse with dexamethasone than Megace. So it works just as well as dexamethasone, but probably causes less side effects. There's no evidence for prophylactic use, so if you're expecting someone to get cachectic or just want to make sure they don't, it doesn't work. End-stage renal disease, there's actually no evidence for using Megace there. And then the side effects for Megace include edema, thromboembolic events, especially when it's used with chemotherapy. And then suppression of the hypothalamic axis and increased mortality. Whoops. Mortality. So that's Megace, basically. There are other progesterone analogs. Sounds very similar, but different name. I'd never heard, but I think it is time. So then anabolic steroids is really talking about testosterone and derivatives of testosterone. So this may be beneficial for men, hypogonadal men, who have advanced HIV/AIDS or long-term opioid therapy. So testosterone replacement actually increases body mass and muscle strength. In those particular situations, there's no evidence for use of testosterone conditions. There have been a couple of other testosterone derivatives used clinically. Oxandrolone is one, nandrolone is another. Nandrolone is very difficult to use. Beyond a study that hasn't really been looked at. But they do seem to help improve body composition and muscle strength. But long-term safety and optimal doses, they're not used a lot. Enobosarm, I don't know why, but that reminds me of the bonobo monkey. I don't know why. The SARM in enobosarm means that it's a selective androgen receptor modulator. It's actually undergoing phase 3 clinical trials right now for weight gain and cancer cachexia. Positive results there. As far as I know, not got all the way through the clinical trial pathway. So then the one that seems to be talked about more than any other treatment at the moment is anamarelin, which is a ghrelin analog. So ghrelin is a ligand for growth hormone secretagogue receptor. So what it does is induces release of growth hormone and other factors, and what those do is increase skeletal muscle mass at the expense of tumor models. So it's supposed to switch back to preferring increasing muscle mass rather than the overall thing that seems to be happening in cancer cachexia is we start getting rid of muscle to benefit the cancer. So we're trying to switch back direction. They have used growth hormone, human growth hormone itself. They have given it to animals, like used it in animal models of cachexia, and it does seem to actually help by just giving growth hormone. But it's really bad to give human growth hormone to people. It kills them. We don't do that. It doesn't. We don't. We don't give ourselves any growth hormones. We probably do for other things, but so they tried using ghrelin, so that actually stimulates us to secrete more growth hormone. Exogenous growth hormone. we're using. But ghrelin, and it works quite well. It decreases utilization of fat, increases resting energy expenditure, stimulates feeding. Stimulates feeding. Sounds like they're talking about hair. It actually promotes appetite, or improves appetite. But administering ghrelin is a bit finicky. It can only be given parenterally. It has a short half-life of less than 30 minutes, so it's not very practical just to give it to appetite and cancer. Yeah, or even maybe continuously if you want it to do not just improving appetite. Yeah. So anamarelin, I don't know if you said ghrelin, is a ghrelin analog. It's well tolerated and absorbed. You can give it by mouth, and it has a longer half-life. There's been a couple of really big studies. The Romana 1 and Romana 2 are the most well-known, but there have been others. So it increases lean body mass by anywhere from 0.5 to 1.5 kilograms, which is not a huge amount. Better than losing. Yes, it will make a difference. Yeah, I would know this because I weigh myself every day. But yeah, but it doesn't actually seem to improve strength measured by hand grip compared to placebo in patients with inoperable late-stage lung cancer, have cachexia. So there were some secondary endpoints looked at in those studies, all of which seem to improve in the anamarelin group compared to placebo. That includes total body weight, fat mass, appendicular lean body mass. That's our lean body mass in the arms, and also improved anorexia cachexia syndromes. And it showed a non-significant trend towards improving fatigue. So all those are good things that make people feel better. There were some mild treatment-related adverse events that really happened only very slightly more often in the treatment group compared to placebo, and those included diabetes and hyperglycemia, mild nausea, and most of the patients that were in these studies were also on chemotherapy. So it's hard to pick out. Some of that was probably to treatment in both groups. And there have been other studies which shows no evidence of impact on overall survival. So it's not going to be that is not the holy grail to cancer, which I was hopeful. So that's anamarelin. I think that one may be something we may want to know about for the exam. It's a whole bunch of other therapies, thalidomide being one. That's it. The next bunch are all cytokine modulators, anti-inflammatory modulators. So thalidomide is anti-inflammatory, and it inhibits tumor necrosis factor alpha. There were early studies showed that patients with TB and HIV did have some weight gain on thalidomide. There's been a Cochrane review that doesn't show enough evidence, that shows there's not enough evidence at this point to support its use in patients with advanced cancer. And there are some significant adverse events, including constipation, peripheral neuropathy, rash, which make it not something you could just throw someone for fun. Rash. Well, if it's not going to help with rash. Yeah, they didn't mention it about birth defects. There are a bunch of other treatments targeting tumor necrosis factor alpha, including etanercept, infliximab, and pentoxifylline, which all target TNF-alpha in different ways. None of these actually have a significant result in advanced malignancy. I think at least enosercept they're still looking at, and maybe the others as well. A chysopentanoic acid, which is an alpha omega-3 fatty acid found in fish oil, is something that I've heard of a few times with regard to improving nutrition. This seems to decrease adenylate cyclase activity, decreases lipolysis, tumor-derived lipid mobilizing factor, and may also suppress IL-6. So those are all things that you might expect to improve cachexia. So early on, it looked like there may be some improvements in appetite and weight gain, but so far, larger studies and a Cochrane meta-analysis have not shown that there's enough evidence for this. People have looked at NSAIDs and COX-2 inhibitors as well. There's quite a few studies on this. The main findings seem to be that there's some evidence that Celebrex 200 BID may be associated with weight gain. My mouth's watering now. Me and Megan can't eat them. Yes, so it is associated with weight gain, increased BMI, and some improved quality of life compared to placebo in patients with cancer cachexia. And then adding ibuprofen to Megace did seem to improve weight change and quality of life compared to Megace plus placebo. Some evidence that those may help. There hasn't been a lot of studies, big studies, or systematic reviews to sort of wholeheartedly endorse them, however. Yes. Well, remember, I also said some of these studies, some of them find, yes, it does this, and some of them find it doesn't.
Inflammatory condition.
Yep.
Yeah, I see why they went down the anti-inflammatory route.
No, I know. Yeah, I didn't find anything that looked at that. Yeah. There's a whole, we're going to talk a little bit about combinations, and I didn't put in all the combinations, to a lot of them. Yeah, it makes sense to me if Celebrex by itself help with some of these things, but I don't.
Mechanism of action for Megace. I guess progesterone. Yeah. I don't think I've ever known that. Yeah.
Probably somewhere. I think
it's not really ever like alluded to, but maybe right. But what I'm thinking, because we've just gone through the complex pathophysiology, you're like, where does Megace fit in with one of those pathways, like versus alpha, or I think that they probably started using that before they even knew all that pathophysiology.
Yeah, I don't know. It's listed as an appetite stimulant, but how?
Yeah, which is probably why they started testing. But I just wondered, did it ever link back to the pathophysiology?
There is,
But now that they understand the pathophysiology, it makes sense for studying like ghrelin and tumor versus alpha thing. Yeah. It makes sense that they're studying those because now they understand pathophysiology better.
But do I think we do, but
yeah, it's complicated, multifactorial, probably in everyone. Maybe it's just that
The mechanism by which the activate is unknown and it's affected.
Works for me. I don't want to.
I know.
I don't want to memorize another record.
He got in, got grandfathered in because before we knew anything about the.
Yeah, yeah. Trust me.
Yes. So yeah, so yeah, we'll mention the Megace plus ibuprofen again. Just back. A couple other things I threw in here, because they are used, but I don't think they're used a lot. So cyproheptadine, which is a histamine and serotonin antagonist, has been found to be helpful in carcinoid syndrome only. The anorexia cachexia, appetite stimulation, doesn't seem to increase weight. But that's the one situation. I don't know if that's just because it hasn't been looked at anywhere else. I don't know if there's something about carcinoid syndrome that makes sense that it works. I don't know. The dose is 8 milligrams 3 times a day. Anyway, someone anorexia cachexia and carcinoid syndrome. Well, if we ever have a cachexia clinic here in St. John, whoever gets stuck working in that will probably be me now, won't it? Right? I will have to know that.
And if I saw someone carcinoid syndrome with cachexia, I think I'd be too crazy.
Probably, I mean, this would be enough.
Oh,
Try a cyproheptadine, yeah. Whatever it is.
Cipro, yes, sorry.
Yeah. So, yeah, so. I mean,
I've tried this one. I read it once and became adoring.
People probably have like 3 people with
carcinoid
syndrome.
Yeah.
And Emily will be the one to try it because she'll have read this and memorized it. All right, so insulin probably does also have an anti-lipolytic effect. Talked about already that complicated involvement of the pancreas in full pathogenesis. Insulin has been given to people with cachexia, and it did seem to increase carbohydrate intake, whole body fat, and overall survival by about 50 days, but did not improve exercise capacity, appetite, body weight, quality of life. It did actually help in some way. It made people feel better. It made them fatter. It did not make them feel better. It made them fatter, and they live longer.
Oh, and same thing with Megace. In a way, like it doesn't improve quality of life scores. That's why I'm always reluctant. Although if someone feels like I could just eat something that would have better quality of life, and I'm like, okay,
yeah.
Right, and then the clotting risk. Especially like it's relatively contraindicated if they had a embolic event. So I don't know how much to push, although I have prescribed Megace.
I sort of always didn't because I know the few times I did use it, it seemed to work all that well and doesn't actually translate into physical changes that mean anything. But people want to
eat with that quality of life.
Yeah. 50 days. I don't know. About 50 days.
The other thing is too, like sometimes we talk to people like this: do you want to live longer or live, better?
Yeah, I think when people they know if there is something that can help them eat more, if they can't, they just can't. If they can't, that's gain weight.
Those are the people I probably spend if I didn't feel they're.
Yeah, I guess too. The other thing I think that's becoming more clear is that if you can, especially early on, like if you can reverse some of this, you would expect people to live longer. There's not a whole lot of talk about survival and
like early intervention. Therefore, they need more people to take modifying.
That's the hope. So, and then the combination therapies, we talked about the Megace plus ibuprofen better than Megace alone. I was getting tired, but I just put in a whole lot of
Dex.
yeah. Yeah, I didn't find that one.
No, I've never seen that mentioned before, but I was like, they both kind of work. And Dex is anti-inflammatory.
Yeah.
Boom.
Yeah.
I'll do my next trial.
I think I don't know if the mechanism of action is maybe assumed to be similar. So, and most of these combinations, they're looking at things that don't work in other things that work in the same way. And hopefully the side effects don't work in the same way. So yeah, Megace plus carnitine plus Celebrex plus antioxidants. If you put throw all that together, it's better than Megace alone. Although I think we talked about one that said Megace plus carnitine wasn't any better than Megace plus Megace alone. So I mean the carnitine you do that, who knows what's there. I mean we know Megace plus ibuprofen is better, so maybe take the carnitine. Those are the oxidants. So maybe that study is about Megace and Celebrex. Megace. Megace plus thalidomide seem to be better for body weight, fatigue, and EPOG status than Megace alone. Megace plus Iso, I don't know if I think that's right, the EPA. Megace plus EPA plus carnitine and thalidomide was better than any of those four things by themselves. Megace plus, there we go. Megace plus Celebrex did not show significant improvement compared to Megace plus placebo. It seems quite random to me. So does that mean, so if it's Megace, you can't, I don't think you can compare these to each other necessarily, because Megace plus carnitine wasn't better than Megace alone. Megace plus Celebrex is better than Megace alone. So is it really Megace plus the antioxidants? I don't think so, but anyway, some study, this is why it's anyway, and then Megace plus meloxicam plus EPA are not better than meloxicam plus one of the other two. Yeah, so yeah, I got tired of one. So Megace, so it's really the common one there is meloxicam. So meloxicam plus EPA and Megace is not better than meloxicam plus Megace or meloxicam plus EPA. Putting the three of them together is not better than meloxicam plus one of them. And so the end result, the conclusion from all of these studies, plus a bunch more put in, is that we need to look more at combinations treatments.
Like pain is complex. You get just focused on the opioid. I bet you pain, I don't know, I'm just making this up to help me understand this. Like pain, if you had morphine plus Tylenol plus pregabalin versus opioid, morphine alone. Yeah, maybe because it's such a as we now know from Robin's talk about like how complex all those pathways are. And so now we know how complex.
Yeah. And I think individual people you don't contribute probably to pain, but also to cachexia. So throwing a whole bunch of stuff there. Hoping for that. And then we're almost there. On non-cancer cachexia, treatment for non-cancer cachexia. So cardiac cachexia, apart from the other things we talked about, optimization of heart failure management is really the mainstay of cardiac cachexia. COPD, cachexia seems to be fairly important in pulmonary, in COPD. The marked increase in mortality in pulmonary COPD. Nutritional treatment can help it is encouraged, and that really basically means providing sufficient caloric intake to meet metabolic requirements, but also induce weight gain. Exercise is encouraged, as this is felt to increase appetite and weight in these patients and increases exercise endurance. And they talked particularly about pulmonary rehabilitation programs. And then if those things don't succeed in increasing weight, then you can try Megace or oxandrolone, interestingly, which may help. Chronic kidney oxandrolone, that's one of the testosterone derivatives, which we don't know what the long-term benefits or adverse profile is. We don't use it, we use it. Some conflicting advice out there. These things. Chronic kidney disease. This is it seems like a little bit of a different beast than cachexia and the other syndromes, both in how you treat it and what's happening. So they mentioned that nutritional supplementation is a good idea, but it's also a bad idea because generally we're trying to feed people low protein diets to try to slow the progression of chronic kidney disease. So it's a bit challenging to feed them up and not give them, but not feed them too much protein. If delayed gastric emptying is involved, probiotics may be helpful. Megace is not recommended in CKD, mostly because there's no evidence that actually does anything and can result in side effects. Exercise does not seem to improve lean body mass, CKD, but can improve strength and physical function. Some evidence for androgenic anabolic steroids, but as we said before, long-term efficacy and risks are unclear. So that in the oxandrolone started. And then they have looked at sodium bicarb because metabolic acidosis is felt to be part of this process, and that's under investigation, but there's risks involved in that. End-stage liver disease, comment that I could find about this is that protein calorie malnutrition is common. I think is really a surprise. And then HIV/AIDS, basically the treatment for HIV wasting is treating with antiretroviral, treating the disease. It used to be a much bigger issue before the advent of antiretrovirals. Less of an issue now, and really the best treatment, like I said, is antiretrovirals to treat it. And that's, yes, that's right. Except, well, yeah, and so what the comment was about that, I think, was that there is some evidence that abalone helps, but you don't really need to use it. Abalone, yeah, sorry. Yeah. But you don't really need to use it. That was really awesome. Anyway, that was kind of everything yeah. Yes. Yeah. Yes. Yeah, I meant to mention that I didn't really talk about, and I probably should have, but talking about those secondary nutritional symptoms, anything that can affect oral intake, nutritional intake. Yeah.
I think it is recommended here in the chronic prokinetics may be helpful.
Yes. Yeah, and that goes for, constantly. Prokinetics for any gosh, all of those things. I'm not sure I put a line in that one. Okay. Basically, pain is one. All right, so how do we treat pain? I should add a line about that.
Yeah.
Yes.
That
Yeah,
way,
no,
yeah.
and I think all I would add is that should be treated.
Oh, I got that. Was he saying that like should be thought of more often? Like the podcast listen to?
Yeah,
Like,
when I was. Right.
mhm.
Yes.
And also waste.
Yeah. I wonder if it only helps them in two.
With medical marijuana has pretty minimal side effect profile. One of those two-week trial or something.
Yeah. I mean, unless you can read all the different things, and I mean,
I know people have early satiety for so many reasons that it's if someone mentions early satiety, I'm like, that was the magic word. You're gonna get metoclopramide.
Yeah.
You get full fast. I need to print my plan.
Yeah.
And I think when I was doing my like not as depth as this, thank you so much. I did read a little something on metoclopramide and like pushing the dose higher.
Yeah.
Than my typical like 10 QID max, but going up. I just read it in passing.
Read about not going to QID, like going above TID. Well, like I've heard that too. I mean, I used to go to 20 more often than now.
Yeah. I don't see it that often. I do see Q. Like I saw some oncology by the oncologist ordered for metoclopramide, and I was like, ooh, interesting. Like, well, yeah, like I know. I didn't touch it because I was like, I wasn't there for that. And nausea was settled by the time I was there. So yeah, I did just random in passing, like doses up to, something more than that.
I know. We used to.
80 milligrams per day or something.
Yeah, I know. We used to go in cases, so they up to 20. Just don't do it anymore. I don't know why.
Yeah, I don't. I've never used 20, but I have. Yeah.
Yeah. Not insignificant.
We do have it. It's pretty miserable.
Yeah.
Thankfully, it's somewhat infrequent, but
Yeah. Oncology. Not wanting anybody else. More common.
they do mention prokinetic. I suppose there's other options. Less. Like with prolonged Q. Well, both can prolong Q. Higher doses of domperidone is can metoclopramide, is it one of the event like ondansetron is How are you doing?
Sorry, I can't always hear when you guys are discussing. I only catch like half of it, so then I start.
Oh, sorry about that.
That's okay. So I faded a bit at the end. But thank you very much. It's more than I ever have known about cachexia and probably ever will again.